So Barry, take it away, Barry.
Thank you, Sam. So this has been quite an experience listening to practitioners from all over the world, from lots of different backgrounds. And to say that collaboration is essential is really an understatement. And I think this whole event has underlined that. What we want to look at today is how do we make collaboration more real, overcoming the obstacles that stand in front of us. We're just going to show one slide this whole time, something, build a new model that makes the existing model obsolete. And Mark, you have done for us exactly that. And it almost astounds me to think that the existing model is starting orthodontics at age 7 and maybe putting braces on at 10 or 12. And all the while, the new model was right in front of us. And that is orthodontics from age 0 to 6. And this is the model that the new International Pediatric Orthodontic Society, headed by Kevin Boyd and Patrice Bergeron, will hopefully be spearheading to look at this very issue.
And it's important to note Barry Raphael and Steve Carstensen, who are co-chairing this, will be founding board members.
And what we're talking about today, collaboration, also requires a similar change in system. While medicine often has plenty of ways of collaborating, and by bringing specialists and allied health professionals into a single office where a single fee can be charged, dentistry doesn't have that yet. And there are obstacles to that. So what we want to do is have everybody here who's broadly experienced answer the 2 questions. Number 1, what's the problem with carrying out collaborative care today? And what do you see as the future? What are your favored visions for, say, the next 5 or 10 years? Steve, would you like to chime in on that? Unmute yourself first, Steve.
Things the right way here. So one of the things that I also want to add to the reframing, the new system, is that medicine, of course, defines breathing problems in terms of the parameters that they came up with for adults all these years ago, obstructive sleep apnea and others. And dentistry tends to also frame the problems that they look at in terms of orthodontics. And we've been struggling with that with some terminology. What I want us to do is reframe it in terms of what Kevin talks about, the craniofacial respiratory complex, the whole structure of things. Orthodontics is part of that. And certainly that's one of the techniques. But if we identify where the actual problems are, then we can apply any treatment, whether it be orthodontics or medicine or surgery, whatever is necessary, if we properly diagnose the situation. So I want to get to a new diagnostic system, a new way of recognizing where the actual problems are. Because the reason why it's so appropriate for this conference is because myofunctional therapy, of course, has a great deal to do with how we can help get a child who's off on the wrong growth path back onto the right growth path, when it's still the right thing to do, just to be so non-invasive, is to get better habits going. And as opposed to waiting like medicine wants us to do, or even orthodontics wants to do, like you said.
Great, thank you. So I'm going to go in order of the squares on my screen. I guess that'll help me not miss anybody. And apparently everybody's screen has different square orders. But for me, the next is Mark Cruz. Mark is a interdisciplinary practitioner from Southern California and a good friend of mine. Mark, you want to answer those questions? Put yourself.
Nothing like drawing the short straw right off the bat, being the first one. Well, I'll try to dedicate a minute to each of the questions. So I think the problem is largely in the West, where our healthcare is very hyper specialized and siloed. So the problem is the system to begin with. And so for me, the model that I like to follow is the ICHOM model. It's a consortium that started in Europe. It's the International Consortium of Health Outcome Measures, which brings up the second part of the problem, is that we largely don't measure outcomes quantitatively. It's very qualitative. And I think to have general agreement, we have to have outcome measures that we can measure beyond subjective. It's not to say that qualitative is not important. In fact, it's very important, but we need to integrate those two things. So I think it's essentially, when you understand that, transcends dentistry. It goes across dentistry, medicine, allied health. And so that speaks to the other problem having to do with interdisciplinary communication. So I think the solution is to be able to have an electron health record of some sort that's more universal. Medicine's been grappling with this now for about 20 years. But to have one that dentists can be comfortable with, they've been very reticent up to this point to really embrace that. And of course, it'll bring our allied health professionals closer to us in being able to collaborate with them. So I think being able to have that, and so the last 12 years or so, I've been working on that, and we're very close to providing that. Rick, I know, will talk a little bit about that. He spent a good part of his career doing that, and that's how we've partnered. And we don't have enough time to go into the details, but I think that's going to help to transcend across all healthcare providers, and to have patient-centric versus provider-centric outcomes. 2 minutes.
Very good, Mark. So proud of you. And let's bring up Analia Goretto. She's one of the world leaders in myofunctional therapy. Anna, if you'll unmute yourself first, and then tell us how you see this problem. And you'll have to unmute your microphone on the lower left.
Thank you for inviting me to this Congress. I appreciate too much the invitation, and I try to be clear with my English. Well, I think that the team, the multidisciplinary team, is very important. That is why I ask two persons of Argentina, Dr. Alejo Biolcati, ENT, and Dr. Gabriela Del Chino, orthodontist, to share with me the lecture, because I think that the team must be real, as you say before, and we have to talk the same language and to understand what the other person is saying. Because, for example, nowadays it's impossible to see the patients all together, but if we can know what is the evaluation of the other members of the team and what is the diagnosis, the oral myofunctional therapists can be able to do the treatment correctly, because speech language pathologist has many areas, but this is a special area, and in which we can we have to understand what the dentist is saying, and knowing what is the ear, nose, and throat diagnosis. Because if the patient has an obstruction, it's impossible to make exercising with the patient. And it's different if the patient has a facial biotype, a different facial biotype, or class more are different to another one to make the treatment. I don't understand I don't know if you understand what I'm trying to mean in English. Anyway, what I'm trying to say is that we have to talk all together the same language to understand what we are going to do with the patient. And that is now is very important virtually, because we can't do it in another way. But I think that every member of the team has to know what it's doing with the patient, and all together has to talk the same language and the same code of language.
Good. Thank you very much. Steve, you want to do the next introduction?
What?
Steve, you have to unmute yourself first.
All right, well, there we go. All right, the next person on my screen is Derek Nordstrom. And Dr. Nordstrom may not remember, but in my first year of running Dental Sleep Practice Magazine, I reached out to him because I didn't know who he was, and I found out quickly who he was and why he's so important to our field. And so those notes are always special to me, and I actually read them not infrequently. So Derek, take it away.
Thank you, Steve. And you are truly a pioneer in pulling this together along with Mark and Barry. We have practiced this collaborative approach since 1981, including physicians in 1983. And as a result, the Cranial Academy and even the Osteopathic Association have begun sponsoring courses to include physicians and myofunctional therapists, nurses, and we've really fought to be able to get physical therapists and other health professionals to be able to go to the courses. So it's sort of begun, but what I see as the problem is that there still isn't, and there won't be a agreement for quite a while because we're growing so fast in our understanding. So it's a little bit premature to try to come up with too many standards. But what we can do as a solution is publicize those centers that are practicing collaboratively and make it sort of almost a requirement that residents or interns in various health fields get a chance to rotate through. This is what I just did. We have physicians that are going through rotations through the different centers that we work at, and it gives them a chance to see what is working, and then we'll be able to grow on that. So I recommend that one of the beginning points is to better publicize centers that are actually accomplishing the collaborative process.
Very good. Thank you so much. Kevin, as president of the newly forming IPOS, can you tell us your vision for collaborative care in the future?
Yeah, thanks for the opportunity, Barry. Co-president, by the way, with Patrice, and you on the board. But anyway, we have an identity crisis. We in dentistry have an identity crisis, and it's of our own doing. Okay, and Steve and I have been working on something with the, the Endeavor Collaborative, but the identity stems from the fact that oral health, the list of components of what constitute oral health, sleep and airway hygiene is not on that list, and that is going to be a priority of the new, Pediatric International Society. What happens because of that is that physicians think that we fill teeth and we take care of gum disease, which we do, and we do very well. So I say a solution would be for us to always, at least in the deal with pediatrics, deal with the pediatrician, the PCP. When you want to make a referral, don't do it directly unless you have to. Sometimes, depending on where you're located, you have to do it directly. But give the professional courtesy to the pediatrician or family physician to help you. And that's another way of letting them know, hey, I do more than fill teeth. I'm a sleep medicine consultant at two tertiary care hospitals. And most of them really appreciate it. I have a form letter, dear primary care physician, that I would share with anybody, that I share all the time. This is how I communicate, and this is how I let my physician brethren and speech pathologists, myofunctional therapists know that I do more than fill cavities. That's it.
Okay. Rick Robley was in dental school the year behind me at Baylor, and it didn't take long for all of us in the school to know who was going to be like the top student. So then when your book came out, Rick, it was amazing because that was interdisciplinary from the get-go, and that's how you've always practiced. So looking forward to hearing what you have to say too.
Well, thanks, Steve. I am proud of you and what you've done, especially with the ADA, and I'm proud to be part of this group. I'm really glad that I jumped in, especially with Mark and Barry. We're doing some amazing things. But where I want to jump in is where Mark left off, and that is I think from the get-go, the way all our structure is in collaboration is incorrect. Everything is provider-centric instead of patient-centric. Provider-centric is how all our EHRs are built and everything, and it is so a doctor or a group of doctors can treat a patient. Where a patient-centric record and approach is all about the patient. Why is it that every patient we see, everybody starts over on? We need to have a common approach, like Mark says, so we get all the right data that we can compare afterwards and go through as a team and have all the records in one place that's accessible by anybody in HIPAA compliant. So we'll talk a lot about that. As far as what other things I'm excited about is, for the first 20 years of my career, I was like most orthodontists when I was a structure guy, and I still am a structure guy. But I can't tell you how much my philosophy's changed when I started really figuring out what function and behavior was the root of all this, even with my TMD patients. And so I've changed radically. But where I think it's important going forward is the structure, which is important. We got to change it so that the function and behavior can follow. We need to break it down into fundamental components that we know not only the boundaries of what we can and can't do, but we have tools to treat almost every specific aspect if the team knows that. And it's all about being on the same common platform. And so I'm really excited about this, and I'm thrilled to be part of it. Thank you very much.
Thank you, Rick. The second person to influence me the most once I learned that orthodontics was not just about the teeth was Joy Moeller. She had a conversation with me that had alerted me to the breadth of this problem. And I'm very proud to introduce Joy.
Thank you very much, Barry. Well, my takeaways from this, first of all, is what is the problem? Well, in the United States, I can talk about the problem is there is no one profession that has actually taken over myofunctional therapy. Speech pathologists in the schools are not being taught this. Dental hygienists are not being taught this. Physical therapists are not being taught this. Dentists are not being taught this. How can we expect them to champion this profession with a postgraduate training? I've been to Brazil. I know how they discuss function. The difference in Brazil is most people are breastfed. Most people look at the children differently than what we do here with the baby food and everything else. So in order to do this a solution, I feel, at least in the United States and in other countries as well, because I've been to many, many countries teaching this, the solution would be a gradual introduction to a profession of its own called myofunctional therapy. And that day will come. It'll be separate from speech, separate from dentistry, separate from sleep even. It'll become its own profession. That will happen. And until then, we need to be cognizant that other countries are trying to absorb this the best they can. I know a lot of people would like to simplify this profession and to dumb it down into just wearing an appliance in your mouth or doing 2 exercises. It's not going to happen here. In order to do the best job possible for the patient, we have to backstep, do a lot of different exercises. I know it's tedious to do all these things, but people need to train to learn all the ins and outs. And then through experience over time, they will simplify and create a profession that is easily implemented into society. Okay.
Steve?
Okay, our next speaker is Marielle. She is going to help us understand more about collaborative care together, especially for young kids, which is, of course, near and dear to many of our hearts. And so tell us what you think the biggest problems are, please.
Hi, thank you so much for having me here. I'm so excited. And to piggyback off of what Joy was saying, so in the United States, I'm lucky enough to work with a collaborative approach and team with Dr. Robbins and Nicole and with Joy and clients. And in Los Angeles, we're able to execute that pretty well, but not everywhere. And I would say one of the main things in the United States is that a lot of the initial screeners who could really help us get early intervention with a lot of the children are not properly trained in this, and they're not airway advocates in that sense, and they're not looking at the airway patency. So pediatricians, for instance, like where it could start there, and we could send them an initial screening tool so that they could kind of understand what is going on with the child from a functional standpoint. As an occupational therapist, I really look at the function of someone. And when people are more concerned about like head circumference or weight gain and things like that, but not looking at the development of the child and how reflux might be impacting the ability to do tummy time, which will then impact motor skills, which will impact the overall nervous system. That's something that can really, that ripple effect can be stopped earlier if we have better screening protocols, I think, with pediatricians and anyone who's really focusing on the child early on. So that's a solution I think that would be really appropriate. And also doing screenings in the schools. So preschools, having screenings, how we check children's vision and how we check their ears. Why are we not looking at their airway? And any children who has any behavioral issues or sensory issues and things like that, really getting into making sure that all their biological needs are met, especially their airway and sleep, to improve their function. So that's kind of my 2 cents for that.
Right. And the work that you're doing with Gila and Nicole is the epitome of collaboration. And let's bring your partners on to finish your point of view. Gila, as the pediatric dentist in this triad, tell us about your experience with the collaboration and where you think it really needs to go. What are we missing so far? And just unmute yourself first. Yeah, there you go.
Okay. Yeah. Thank you so much for allowing me to be a part of this collaborative team. So many of my mentors and dear friends are here today having this discussion. So shout out to pretty much every single one of you, really. I agree with everything that everyone is saying here. What I want to bring up is when we talk about the tongue is foreign in the sense that when you think about specialties, who is the specialist over the tongue? What specialty owns that? Think about it. It's actually the unifying anatomy of our body that unifies all of our professions. And this is a major reason why we have to all work together and collaboratively on this. I agree with Joy in terms of having a profession, even a PhD or a doctorate in myofunctional therapy so that we can really support our patients. In terms of, I think the biggest thing that the problem is communication and communication interdisciplinary with other professionals. I do think that they feel that when if I'm not talking about teeth, they think I'm talking from some other planet, really. And it's really patient driven. What I found is when they see results and that their patients are getting better and healthy, it sparks them and they become interested. So I think Kevin's point about sending letters to the pediatricians, sending out information and getting them involved is really important. I would say initially I tried to do that, but then they would kind of shut me down. But as we progressed and got our team together and worked together, they're much more on board. I also found that even in pediatrics and with pediatricians, there are developmental pediatricians. So you have your pediatricians where kids are just going for their well visits, or they're going because they're sick, but then you have a subdivision of developmental pediatricians that are dealing with children that have a lot of underlying issues. And that is a group of pediatricians that I really went and kind of outreach to them to share what we have to contribute and what we can do to help these patients. So that's pretty much what I have to add, but I agree with everyone on this panel. I think we all have something that we can contribute to make it grow and spread. But I do feel that communication amongst different professionals and healthcare professionals, and I do feel that it's going to be patient driven, that when results come and they talk and speak, and I know you're doing a phenomenal job getting patient voices out there so that when their voices are heard, then their doctors hear it, and then they find avenues on how to help their patients.
Yeah. Listen, we've learned from James Nestor that we're all pulmonauts, and we're learning from you that we're all linguologists too. So speaking of linguologists, Nicole, you're the third on the team, the myofunctional therapist. Why don't you tell us a little bit about how you're seeing collaboration? Yeah,
thank you, Barry, and thank you, everyone. I really honored to be with all and colleagues, and that really has been a great gift in my career.
See if you can get a little closer to your mic for us, Nicole.
Okay. Can you hear me now?
Speak loudly, and we'll be able to hear you.
Okay, I'm gonna shout. Can you hear me?
Yes, that's fine.
Okay. So, did you hear anything that I just said prior to that? Yes, no?
No, start again.
Okay. I'm honored to be with so many people here, like Hila said, have been all of you, and I thank all of you for taking time and caring enough to be here. And really acknowledge what Steve said at the beginning. And I think everything we do is really predicated on hypnosis and getting children back on that right path. And I think this is how I look at the problem, or how I try to address it as a language pathologist. Working with children, I recognize that they get one childhood. You know, it's not two and it's not three. And so where we start with families and getting that proper diagnosis is what is going to help build an entire team, because from that point, then we have to understand who are our team players, who's in our community, and what are their skill sets that are unique and individualized to the needs of that child. I agree with Mark that what we do is patient-centric. And I think from a therapist's perspective, when we get families and patients and we can really help them see the connections to functions, that's when it starts clicking. And we don't have a lot if we don't have patient buy-in. And when you start to connect to functions and the impact to their daily lives, from what we know from the impairments to the craniofacial respiratory complex, those impacts to daily life can just run the whole gamut, and it can be a lot. So I think it's having that communication on the value of the functions we're seeing impacted, how we bridge team members in our communities, and really understanding everyone's skills so that we know who's not just the best fit for their specializations, who just might have the temperament to handle a certain patient and family a little bit else. And I think within our teams is front and center, and getting on the same page and being able to convey some of the same messages to, because they get confused when they see 5 or 6 different people. I think the clarity of our communication to families and is really important. And I think that's all I have to say on that. I could probably talk longer, but I respect that everyone else has some things they need to share, and I'm anxious to hear what other people have to say as well. Thank you, Barry.
One thing I want to add about Nicole is that, you know, we know that she's passionate about this like the rest of us, because I see Nicole at all these meetings in every place. And so, so you're everywhere. So it's excellent. So additionally from Brazil, we have a leader from myofunctional therapy in Brazil. Pardon me if I pronounce Guiedre inappropriately, but we have somebody who's actually setting standards down there. So let's let her have this, her input here.
Hi, thank you a lot for introducing me. I am so happy to stay here with this wonderful group of professionals. And it is a pleasure to talk about the multidisciplinary team. I have been working with patients presented with breathing, chewing, swallowing, speech and voice disorders, especially adults and elderlies. The interdisciplinarity is very, very important and necessary since the diagnosis until the end of the rehabilitation process. Working in the face-to-face care and also in the telepractice, as in this moment because of the problem that we are living. In the University of São Paulo, Campus Bauru, speech-language pathologists work together, not only with dentistries, physicians, physical therapists, nutritionists, psychologists, but also with translators, computer scientists, web designers, and other professionals who can add knowledge in order to improve the quality of care and the care access for patients presented with myofunctional disorders. But to work together, we have to know each other's. When one profession really enters in contact with another one, both are changed, improving the comprehension about their practices. For example, I studied a lot about dentistry, but not to work as a dental clinician, but to understand how can the speech-language pathologist can help dental patients in each moment of the treatment. I hope that my experience can help everything to think about how we can change our practice in order to improve ourselves and to give the best for our patients.
Thank you so much, Yedra. You've been a wonderful asset to the Congress, and we so appreciate your workshop where you're going over your protocols and always looking at the interdisciplinary nature of assessment and treatment. The next person I would like to introduce on our wonderful panel here is Gabriela. Gabriela, we are honored to have you here with us today. And all I ask is that you unmute yourself and show your video. So while you're getting ready for that, perhaps we can have.
All right, I'll do the next introduction. We'll go back to Gabriela. One of my colleagues and mentors, James Bronson, is here. Jimmy, along with Derek and Gavin, have been instrumental in teaching people the biomimetic techniques of ALF. Jim, how do you see interdisciplinary problems and where would you like to see it go? Go ahead and unmute yourself first. Jimmy, unmute yourself first.
Working.
There
better?
Start
Cool. Yeah, thank you. It's a pleasure to be here with you guys. Nice to see you, Barry, Kevin, Gila, Mark. I don't see Mark Muller, Samantha, Nicole. It's a great group, and it's very nice to have a chance to speak with you all. I think the biggest problem we have to deal with, and this transcends all of the discussions that have been going on yesterday and today, is lack of awareness. Lack of awareness with our peers and lack of awareness with the general population. To put that in perspective, I was at the ADA conference last September in San Francisco, standing at Mark Muller's booth, and I said to three dentists walking by, three young dentists, if they knew what myofunctional therapy was. I asked them, and all three of them couldn't answer the question. So we have a problem right there that our peers don't even understand, that there is an issue that we can use to make things better. And that's just one small part of it. I think what we have to do is to get more things like this going on, where we have the potential to spread the news to many more people. I think we have to do it in a little bit different sequencing perhaps, but this has been tremendous. I think that our solution is going to be, as Hila said, through the patients. It's not going to come through the doctors. The patients are going to demand that their doctors learn what we're doing. I think that's really where it's going to come from. We have that opportunity, we have that knowledge, and I think what we have to do is put together workshops like this one, but gear it toward the holistic moms groups, gear it toward the groups that are really going to be out there and grab it and take it further. And they're going to demand that we have more practitioners participating in doing the work. So again, thank you very much. It's been a pleasure to listen to all you.
Thank you so much. We're going to go back to Gabriella here. Gabriella, if you just unmute yourself, and it's a pleasure to have you. You're part of these presentations and in our track here with multidisciplinary collaboration. We'd love to hear from you and your thoughts.
Thank you. Thank you so much.
Would you like to say a few words about your ideas about collaboration?
It's an honor for me to be here, and thank you for the invitation. Thank you very much.
Yes, I encourage you all to review Dr. Da Vinci's work. It's in our on-demand platform, and you can reference that for a very long time. So that's part of what we're doing this weekend, is to bring these speakers and to bring them into another forum so that you can connect these thoughts with the speakers and then review their actual presentation. Barry?
Yeah.
So next, let's hear from Diana Grande-Tropat. If you'll turn your camera on for us and unmute your microphone. We'd like to hear what you're thinking about interdisciplinary care is and where you see we need to go. Diana, are you available there?
Yeah. Okay.
And just unmute your microphone as well. That's on the lower left, where the little microphone piece is. Sam, if you, I don't have control.
We may have lost her, so let's we're running short on time. Oh, is she there?
Yeah, she's there. She's
there.
Just for the mute. There you go. You're on. Go ahead, Diana.
In Spain, there is also interdisciplinary work in many places. In addition to my work as a speech therapist in private practice, I have been working in an orthodontic practice for 17 years, and I teach at the School of Dentistry. Since 2016, in a sleep medicine team. I think that interdisciplinary work is possible, is very, very necessary to do the formation of the professionals, speech therapists, in area of dentistry and dentistries in the area of myofunctional therapy. We collaborate since, I don't know, 2006, elaborate protocols, interdisciplinary protocols for screening. They are very interesting because these protocols facilitate more the detection and the guide to the patient, to the evaluation, to the assessment. It is very interesting.
Thank you, Diana. It really is special to have voices from all over the world and learning from each other. It's really what I think is moving the needle as we get our languages and concepts shared and assessment and treatment tools. I just want to say it's been pretty amazing. We have 27 countries represented in the AAMS 5th Congress. So it's pretty great. Barry, did you want to step in?
So yeah, we go just for 3 more minutes, right?
Mm-hmm.
Yeah. And there's a way for you to raise your hands if you feel like you still have something that you want to say under participants. Just raise your hand for me. Just to wrap it up, the methods that we use to collaborate with each other, both in terms of our techniques and our communications and our locations, are tools that we need to really work on in these next 10 years. I would love to see facilities that have the multidisciplinary faculties on them where patients can come in and get a complete assessment, have the work properly triaged step by step, and then be treated in the most optimal way. My dream is to see that come true. I know there are obstacles in terms of professional licensure and ownership rules and fee sharing and fee splitting rules that have their place. So there's no doubt about it, but also have to be overcome if we're going to be able to maximize the kind of care that we want. Mark, you have your hand up. You want to finish doing punctuation? Go ahead.
Comment, so the thing that ties us all together is something that at some level we all have blind spots with, in that our orthodoxies, the way we're trained to think about it, kind of gets in the way of our communication. I'll just use the example. If you look in the medical literature as how they define the genie glossus, its #1 job is, #1, it's an airway dilator muscle. We're not taught that in dental school. We're taught that it's wet and gets in the way. I mean, if you're a speech pathologist, maybe you're really focusing more on speech and deglutition. Those are secondary and tertiary functions moment to moment. So what keeps us alive is that airway dilator muscle that must be coordinated with the diaphragm. So that all ties us together, including the sleep position. So just something to think about, how maybe we could start talking about the tongue differently.
And Joy, I know you had something you wanted to add to that.
I just wanted to give a shout out to Christian Guimeno as one of my heroes that listened to me, and Dr. Mew, and with his mewing, which has positive things and sometimes people think not so positive, but as far as educating the public, it has been amazing. And my hat's off to you, Samantha and Mark, for bringing this together in such a professional way. It's beyond anything I've ever dreamt of. I just can't say I'm so proud of you.
Well, you are a little biased, but I'll thank you. I wanted to just open it up for any closing statements. This panel is quite the compilation of minds. And it really is, it's more than a village, it's the globe. We're looking at the globe. The only continent that is not represented in our Congress is Africa. So we, we're not there yet, and we definitely need to reach out and bring more voices into the arena to bridge countries, modalities, awareness. And I just wanted to add one thing is that, everyone here is inspiring each other. And again, the patients are what we're working for, and their voices that are heard. It is a new bridge of opening that element to bring our communities into that arena. And I really want to say thank you to the people who instigated that and the development of the Patient Voices Forum. Before we close off here, we have a kickoff ceremony, and I mean that because September is just around the corner, and it actually is full of other content, events, lectures that are still coming into our arena. So the Congress is really opening, and now we have a collection of material and content that we can share and learn from. So please join us in 13 minutes for the opening ceremony. And if you're able to throw on a little black tie, and Steve, if you want to just, we have virtual backgrounds that we can share, and I really do encourage us, come back. It's the same link. For those of you out there, I want to encourage you. This is just getting started. Many initiatives that have really started here in the Congress and before are really going to find more momentum and more trajectories of opportunity to share. So thank you again, Barry. Thank you so much, Steve Carstensen, for your contributions, and everyone here who is really a leader in their discipline. And we are in gratitude, and we hope that you join us in just 12 minutes for the opening ceremony of how this is going to move forward. So thank you again.
Thanks, Sam.
Bye.
Bye. Bye-bye.